With this background, this session is to inform the research findings to all the participants and to inform how the research findings influence the policy decision and national program of maternal, newborn, and child health. Today, we have several guests, several speakers. We will hear 3 presentations of the result from the researchers who were at the forefront of this research project and practitioners involved in subsequent development of the result in the national program, followed by comments from the policymakers of Ghana Health Service and the Director of Research Division. This will be followed by a discussion with online participants. And as you can see, the panelists are here. So let's move to the presentation. The first presentation is a finding from Ghana Embrace Implementation Research by Dr. Akira Shibanuma, Department of Community and Global Health, the University of Tokyo. The floor is yours, Akira-san.
Thank you very much, Makimoto-san, for the kind introduction. My name is Akira Shibanuma, the University of Tokyo, who participate in the Ghana Embrace Implementation Research as a researcher who is mainly involved in the impact evaluation. So I am delighted to present the findings from the research today. So I'm moving on to the next slide. First of all, let us revisit the importance of continuum of care in maternal, newborn, and child health, or we call COC. COC is to ensure that every woman and child receive timely and effective care along their life stages. It has 2 dimensions, time and place. So place dimension is important, particularly for referral, for those who require services upon complications. Time dimension is important for every woman and child to receive timely and required MNCH care. That is why COC is very important policy target. In this study, we mainly focus on the time dimension of the COC. This slide introduces the situation in Ghana, particularly before the intervention started. Maternal and neonatal mortality have declined substantially, but did not meet the national and international targets. The coverage of antenatal care, scaled delivery was high, but the postnatal care here, particularly postnatal care within 48 hours of delivery, which is the most critical period for the mortality reduction, was low. Therefore, the COC completion, so receiving all of these care, was only 8% before starting the intervention. So even though every woman and child needs to receive these interventions along the timeline, the coverage was very low before the intervention started. Therefore, we designed intervention to improve COC, particularly improve the bridge between the delivery and postpartum care. However, to improve these, we need early involvement. So we distributed 1-page COC card to women. So this is the client health, very simple recording card. And we provided COC training for health workers. In addition, so the at least 24-hour retention after delivery and home visit postnatal care were provided where sufficient equipment and workers existed in the health facility. So we provided intervention for health facilities with very minimal investment. This is the design of the COC card. It contains information for the necessary care, essential services, health education, danger sign, and phone number. And you can see the stars along the services. So the letters are small, but ANC 1, 2, 3, 4 delivery and PNC 1, 2, 3. So if women received the scheduled visit, so timely visit, we put the gold star sticker on the card so that we can visualize how women received care along the COC. And they can share the card with the health workers to discuss the importance of the COC and discuss the importance of COC with families too. This study evaluated the effective facilities has different roles. However, to prove both the effectiveness and implementation of the RCT, we took the best advantage of the existing health services, having different types of health facilities without extensive physical and human resource investment, particularly for the intervention. So higher tier health facility have the different services, but in the community-based CHIPs, they have basic antenatal care and postnatal care provided. And the nurses, community health officers basically receive the basic obstetric training to prepare for the delivery. However, the many women receive delivery assistance in these higher tier health facilities. And women could choose any health facilities as they were in the routine health service provision settings. So that means many women visited advanced health facilities beyond community and sub-district. For the research purposes, it might trigger the contamination of the effectiveness of the intervention. So this is the overview of the data collection. The mortality outcomes were collected based on the health and demographic surveillance data. In addition to them, we collected data on the women's behavior and receiving the health services for the baseline surveys and follow-up surveys, both of which had 1,500 women in the sample. This is the result of the intervention. The interventions improved the COC completion at the level of the 47.1%. In addition to the antenatal care and skilled delivery, which were already high before the intervention, so we had the very high level of the coverage in postnatal care, especially for the 48 hours. It was really high after the end of the
Recording in
intervention.
progress.
And however, we see the difference in the coverage by 3 sites, probably reflecting the existing infrastructure and health worker endowment. We can see the strong contamination in the effectiveness of the intervention too. So while the intervention area, the COC completion coverage was 47.1%. It was almost 40% in the control area too. Notably, yes, as we saw, the postnatal care coverage was really high for 3 times in 48 hours, around 1 week and around 6 weeks. Joint coverage was 58% in the control area. In the intervention area. The majority of women 73% in the intervention arm received COC card, which was the proxy for the participation in the intervention. We can also see that 22% of the women in the control arm actually visited a health facility in the intervention arm to receive the COC card. Then received COC card was associated with improved COC completion, notably in both arms. The coverage of COC completion among women who received the COC card was 52% in the intervention arm and 53% in the control arm. Women improved the COC completion regardless of the type of the nearest health facility. In the follow-up period, COC completion was highest among women lived in the city center where the public hospital was located, as had been expected even before the intervention. Notably, women in the remote area where the only community-based health facilities are available, the improvement was really extensive. COC completion improved almost 8 times as high as the baseline. The COC completion was also high among the high socioeconomic groups, such as educated and wealthy. Also notably, the improvement was extensive among low socioeconomic groups, where those COC completion was actually low in the baseline. However, our package of the intervention worked very well to improve the COC completion for less wealthy and less educated women too. We found that maternal deaths were reduced among women delivered after the intervention. However, we did not find a significant reduction in the prenatal and neonatal deaths through this intervention. The intervention period may not be long enough to see the reduction. And also, it would be important to address other aspects of the maternal, newborn, and child health care to improve the mortality outcomes beyond the scope of this intervention, such as the strengthening services at the emergency obstetric care and referral, quality of referral for the high-risk cases. So the other results were published in many publications from this Ghana Embrace implementation research project, but this is one of them. The conclusions. So the package of the MNCH intervention at the realistic health services setting in Ghana actually improved the completion of the continuum of care. The received COC card, one-page card, was associated with improved completion of COC. And intervention was effective among both high and low socioeconomic status groups. Extensive contamination actually occurred. However, it might suggest that, so it is possible that strong spillover and scale up of the intervention can occur in the realistic setting. The secret behind the strong spillover might exist both women, family members, and health workers. So detail of the secret will be mentioned in the following presentations. Thank you very much.
Thank you very much, Dr. Shibanuma, for your excellent and complete explanation of evaluation result of MNCH COC intervention package centered on COC card. COC completion was significantly improved with equity aspects, and that explanation of a strong spillover possibility was also very much interesting. I would like to listen the next presentation as a background. Okay, thank you very much, Dr. Shibanuma. Next presentation is Ghana Embrace Implementation Research Protocol and the AIM Framework by Professor Evelyn, Korkor, Ansah, University of Health and Aligned Science, Ghana. Professor Evelyn, can you show your face?
Okay, thank you very much. And there will be a few things that I may repeat in this presentation, but mainly for emphasis. So I'll be looking at the protocol that we used to get the results that was just presented, and also look at the effectiveness of the implementation. So I'm making this presentation on behalf of the Ghana Embrace implementation team, and I was doing this jointly with Dr. Akiko. So just to step back a bit, at the time of this study that was just presented, globally, over 289,000 women were dying due to complications of pregnancy and childbirth, with 99% of these deaths occurring in lower middle income countries like Ghana. And over 6 million of children under 5 also died in that same period. And 80% of these died within the 48 hours postpartum. This is important because of the postnatal care 48-hour intervention that was just spoken about. So 80% of these children were actually dying around that time. So that explains why what we have done is very important. Now, in recent times, whilst this number of deaths in children has reduced to 5 million, it still remains very high. And the children are dying quite a lot within the first 28 hours of life. So in 2012, the Japanese government conducted race implementation research, and the aim was to create a feasible, sustainable packages of interventions with an aim to improve these outcomes that I've just talked about, this high mortality that we see in lower and middle income countries, and to test these in rural settings where a lot of this was occurring, and to do what we are just doing now, which is disseminate the findings to the wider global health community. So you've seen this already, which Dr. Shibanuma talked about, the cracks in the continuum of care from adolescence right to childhood, through the mother to the newborn, and there are cracks as we go along. And interventions are needed to make sure that these cracks are filled. And also talked about the continuum of care from household right to health facilities. But this study focused on the cracks in the continuum of care in the time axis, as is spoken about, and making sure they are strung together so closely. So the study, as here was indicated, was carried out in Ghana, and 3 different sites representing different areas in the country were selected. So it wasn't all done in one place. Right up in the northern Ghana, where the communities are in remote places deprived, then in the middle belt, which is a forest area, and then in the southern belt, which is coastal, and the Ghana Health Service was working with us on all of this. So there were different aspects of the study. There was a formative research, during which a situational analysis of this continuum of care in Ghana was looked at. And here we use both retrospective studies and qualitative studies. Following this situational analysis, the results that were obtained were used to develop the intervention package together with stakeholders, including the Ghana Health Service policymakers, health providers, to come up with an intervention that will address what we saw in the situational analysis. Then this was followed by the main implementation research. And this is the time where there was a baseline study, the intervention was put in place, and the method that was used was the design was a cluster randomized trial of the intervention package. And you must have heard about the leakage from one place to the other in this cluster randomized trial. Then finally, there was the impact which was done. So this situational analysis showed us where the greatest crack was. And this was in the first postnatal care at 48 hours. And you remember in the background, I mentioned that over 80% of babies were dying around this particular period. And here in Ghana also, we saw that there was low coverage of the first postnatal care for various reasons. And because of that, we had an overall low COC completion rate. And so we set out to adopt parts of the intervention package, and then using the COC card, monitor the mother and the child, the 24-hour retention at the health facility after delivery. Note that at this time, a lot of women, if they deliver vaginally and they deliver and there's no complications, oftentimes go home before 24 hours. So this was an intervention to keep 48-hour PNC to happen before they go home, so that if there's anything, it is addressed right there where the delivery took place. And then we had the home visit postnatal care, where people are followed up at home if they happen to deliver at home, or even after for the next 2 weeks postnatal care. So this is a picture of the orientation of health staff that is going on. These are nurses and health providers from all the health facilities we have. And then you've seen this COC card, and this gold star comes from, the idea came from the idea where children go to school, and if they do very well, they get a gold star in their work that they have done. And so when they come back, they show it to their mothers. And even mothers who are non-literate recognize this gold star as something excellent. And gold in Ghana is aligned with excellence. And therefore, this gold star was selected for that reason. And what I would also add to this is that just to motivate people to aim for this gold star, that is attending the antenatal clinic and obtaining services on time, we also had an orange star. And so mothers that did not quite meet the gold star standard got an orange sticker. So that's what happened there. And then an implementation guide was also developed to guide the training, supervision, and everything of health workers so that this could happen. So you would notice that 2 of the packages were really addressed, and then the 24-hour retention and home visit was targeting the major crack, which is the PNC in less than 48 hours. And the outcomes included an intervention impact, which Dr. Shibanuma has presented extensively on, and then an implementation impact, which I am about to present on. And this implementation impact, the outcomes included intervention coverage, intervention adoption, intervention fidelity, and sustainability. We didn't look at the cost in this presentation. So we used a re-aim framework-based evaluation for this. So the objectives I have talked about already. The intervention objective and its outcomes is what Dr. Shibanuma has presented. So the focus of what I'm about to continue to talk to you about is looking at the outcomes of the implementation. So this evaluation looks at 5 criteria. The reach, that is women's participation rate to intervention component. Then the effectiveness, which is health outcomes and services received, And then the rate of health facilities and women who adopted the intervention, and then there's 10 institutionalized, and we use various data collection methods for this. So if you look at the reach, you see that in the intervention JICA, over 70%, which has been presented already, and retaining them in the health facility for 24 hours after delivery, even though the intervention area was better and significantly so, you see the contamination improvement was seen. And then we look at the area of looking at the health workers' home visit. And you see that again in the intervention area, this has gone up significantly in all the 2 areas. Then when you look at the adoption, which is the other criteria, you see that the COC card was adopted, but the postnatal care 24-hour retention you see was a bit lower than should have been. And this was because a lot of the facilities like the CHIPS compound didn't even have where there was a room. As Dr. Shibanuma said, we tried to provide a bed, a few things for them to retain these women. But in some places, by the home visits, you see goes compensate for places where they come to. So when we talk about adoption, the COC card seemed to have reduced the burdens of health workers and mothers. But the visits increased the workload of the health workers. But it was the only choice for mothers to receive postnatal care because in many places in Ghana, when women give birth for a certain period, they don't go out of the house. So if you are requiring them to come out and come for a postnatal care, they may not come. So in the end, the nurses then went to them in their home and carried out the necessary examinations. So this adoption took place. And this is actually part of the CHIPS program where home visits take place. So this was worked into the Community Health and Planning Services program for this to happen as part of that program. So you see then that the completion rate went up higher in the intervention arm, and the complication risk also reduced in these areas. Now, when you look at implementation, there were various things that influence how well implementation took place. In certain places where the GHMT was not so much on looking at what was going on and being effective in their supervision, the implementation did not go so well. And places where health workers could not ride a motorcycle for the home visit, it became a problem. Where people misunderstood the card use, it became a problem. And where there was an intervention stagnation due to transfer of people that had been trained, that became a stumbling block. But where the health workers, in some places, the DHMT actually trained health workers so they could do that, develop manuals and supervise these health workers. And when that happened, intervention was more consistently implemented. So the DHMT's follow-up was very key for this implementation to work, and we want to put that on record. Regarding sustainability, after the Embrace Intervention Program had been implemented, the Ghanaian and Japanese government collaborated to integrate the COC card in the maternal and child health record book. And I'm always happy to see this in the child health record book. And the new one has replaced the old one almost virtually at this point. And this evidence-based policy was realized following the Embrace Intervention and Implementation Evaluation. It is a very proud thing to see this in the child health record book, to see research going directly and finally into policy. And to conclude, the re-aim evaluation we carried out suggested that this intervention, which was carried out in the Embrace study, has been accepted in the field, and government, private, and academic collaboration has enabled the integration of these interventions to the local health system, and it enables a more feasible, sustainable implementation in the real world setting. So I would like to acknowledge the whole team that took part in this. I'm just one of the team. There was a whole big Ghanaian team from all the 3 sites and the headquarters of the Research and Development Division and the Ghana Health Service, right up to Deputy Director General level, and then the Japanese team, some of whom are here today, and we acknowledge everybody's contribution to this. Thank you very much for your attention. I'm done.
Thank you very much, Professor Evelyn, for your very rich presentations. And it was a very clear explanation that formative research is very important for designing COC completion intervention package in real world setting. And the implementation evaluation using re-aim framework was also very useful. Thank you very much. And I'd like to invite the third presenter, Dr. Akiko Hagiwara, Senior Advisor of JICA. So, Akiko-san, are you ready?
Yes, Makimoto-san. Thank you very much for the kind introduction. I'm ready. So thank you, Madam Chair. Okay. I'm Akiko Hagiwara, a Senior Advisor of Health at JICA. I would like to talk about JICA's roles in Embrace implementation research and also the implementation of the COC promotion in Ghana. This is the major timeline of our supports. Embrace implementation research project was conducted 2012 to 2016 as the JICA research projects. Then based upon this Embrace implementation research, the government of Ghana and Ghana Health Service decided to develop the MCH record book. And I was an advisor, technical advisor for the development. Then JICA started the technical cooperation projects for 4 years for the national rollout of the MCH record book. And all through these processes, the Ministry of Health and Ghana Health Service committed leadership and made decisions, the policy decisions based upon the Embrace evidence. This is the operational structure of the Ghana Embrace implementation research. The core is the research team is managed with the steering committee. The management of the research project is managed by the project director, JICA, and a project manager, GHS. Then the research team consisted with the Ghana team with the 3 health research centers and GHS, and a Japan team headed by the University of Tokyo, JICA Research Institute, JICA Senior Advisor Fujisumi, and University of Osaka and others. Now, JICA contracted those teams and supervised, and overall management of the project has been done with the JICA headquarters and JICA Ghana office. There was an advisory board consisted with the Ministry of Health, WHO, UNICEF, and UNFPA, which has the regular meeting with the research team and had the technical exchange, such as the advice or the reviewing of the research protocol and so on. The implementation was done by the GHS, the Ghana Health Service, the Family Health Division, Regional Health Team, and District Health Teams, and health providers at the health facilities, as you have seen it with the Dr. Evelyn's presentation. The roles that JICA really did in implementation research was plan and finance and manage EMBRACE implementation research projects, analysis of the health systems and health policies in Ghana, and based upon those policies and priorities, we promoted the development of the feasible and practical intervention packages. Now, this is something that we are doing many years in many countries as the bilateral donor in health sector. And we have long year working experiences with the Ghana in health sector. Now, we also promoted dialogue with Ministry of Health, GHS, UN organizations and the development partners, and the research team. We were the bridge, and we established the steering committee and advisory board. We organized the regular in-person researchers meetings. We often had the meeting in Ghana, and Japanese team visited Akira for this in-person meeting. And sometimes Ghana team came to Japan for some occasions, such as DCAT. We also disseminate the research findings at the national and the global level. We finance the scientific publications, and we have conducted and presented many international conferences. Then the research conference in Ghana, which is the domestic conference, but this is very important because this will be attended by the policy makers and practitioners, which will be the foundation for the policy decisions and the service delivery. So the nationally and internationally, we have conducted the dissemination of the research findings. Then we scaled up. We are scaling up the research findings into the national program. This is the picture of one of the conference that we have conducted, the International Conference of EMBRACE Implementation Research Projects. As you can see that the Professor Evelyn is here, that the Dr. Shibanuma is here, and the Dr. Kikuchi, co-author of the Evelyn's presentation, is also here. Oh, and we were working this is the conference that we have done together in Accra in 2016 at the end of the research projects, attended by 170 Ghana research team, Minister of Health, Ambassador of Japan, health administrators and practitioners in Ghana, academics and recipient mothers also invited for this conference. We also invited the Ministry of Health and JICA experts from Kenya, Nigeria, Senegal, and Burundi. The development partners such as the World Bank, WHO, UNICEF, UNFPA, USAID, and KOICA also present at the conference. So we share the research findings and discuss the future direction of the policy decision. At this conference, the Ghana government decided that they will promote the COC with the client-centered approach and decided to develop a combined maternal and child health record book together with integrating the COC cards. So combined maternal and child health record book. The Ministry of Health and the GHS developed the Ghana MCH record book in 2018 with technical and financial support by JICA. It is a home-based records for mothers and children. And it has the maternal health records, child health records, and also the COC cards integrated into one book to fill the gaps of the maternal and child health services with better coverage of the continuum of care. The Embrace implementation research found that women's knowledge, social culture background affected their COC completion, and educating women about the importance of COC was effective to promote COC completion and reduce maternal mortality. So the policy decision made by Ghana government promoting COC with the new MCH record book. So the record book was developed and we trained healthcare providers on how to explain and motivate mothers to complete all COC services with simple language, with respectful manners, and with consideration of mother's social cultural background, so that women, the mother, can make informed decision on her COC. The key features of the MCH record book is the home-based records and ID, together with the information for the pregnancy, delivery, postnatal period, and a childhood up to 5 years in Ghana. Then we also included the Continuum of Care card, the COC cards. This is the updated COC cards integrated into the Ghana MCH record book. Instead of 4 ANC, now we added the 8 contacts of the ANC according to the WHO new guidelines established in 2016. And there is the small letter in the bottom saying that acknowledgements, the COC card has been developed through Ghana Embrace implementation research projects. So as we publish MCH record book, we always acknowledge the work of the Embrace implementation research. The health worker gives the star stamp with the ink. Unfortunately, the gold star stamp was so expensive and it was not feasible for the Ghana government to purchase all that star stamps. So now instead of stamps, we use, instead of the gold sticker, we use the star stamps, and the mother are happy to receive the stars, as Dr. Evelyn explained to you. And we try to encourage mother to complete all COC with the COC cards. So the research evidence into policies and practice. The research evidence facilitated government of Ghana to make policy decisions, and it was the backup and the backbone of the national rollout of the MCH record book. It accelerated the collaboration with partners as well. So MCH record book was strategically rolled out and made significant impact on the promotion of COC in Ghana. This is the graph of the graphic graph of the COC completion rate, starting from the baseline of Embrace, starting from 8%. At the end of the Embrace, it was 50% of the completion. Now, with the introduction of MCH record book together with the COC card, the COC completion improved from 50 to 76%. Then we also made training on effective use of MCH record book And the COC completion improved 76 to 92% at the model districts, where the effective use of MCH record book is done. So Ghana government is strategically promoting COC with the MCH record book. Achievements of the national rollout of the MCH record book in Ghana. MCH record book was utilized at all health facilities that we have visited in 2021 across the country. 83% of the book had the dates and weight at birth correctly filled, which is the recording done well. And 72% facilities took measures to ensure privacy during ANC, which is the enabling environment for the mother, for the discussion and the making for the discussion on the counseling at the counseling. And 91% of the pregnant women felt free to ask a question during the counseling. Look at this picture, the health worker and the mother discussing with the eye contacts using the MCH record book. 92% pregnant women were satisfied that health workers explained the procedures well. 96% of pregnant women mother could recall what health providers advised during the counseling. 95% of pregnant women and mother can recall the dates of the next visit. It's because of the COC cards, it's because of the MCH messages, and it's because of the effective communication of the health workers. So COC and quality of care are promoted nationwide in Ghana with this MCH record book. So finally, this is the final slide. From research into practice, I want to talk about JICA's roles in research and implementation. One, promoting policy relevant research with field-oriented perspectives. Two, disseminate research evidence. And three, transfer research evidence into the policy and the practice. And JICA would continue to conduct the policy relevant research and utilization of the research evidence into the policy and practice, working together with the research teams, academics, and global partners and UN organizations for the sake of health and well-being of women and children. Thank you very much for your attention. And I have some links for you if you are interested in the homepage of the projects and also the project documentaries, which is available in YouTube. Thank you very much for your attention.
Thank you very much, Akiko-san, for elaborating JICA's engagement in this research and the subsequent development of MCH record book and the implementation structure of the research as well. It was very useful how the research was organized and how JICA was supporting the project. Thank you very much. Okay, we had 3 presentations up to now. Then we would like to invite 2 speakers, 2 commentators from Ghana Health Service. The first commentator is Dr. Abraham Rexford Oduro, Director of Research and Development Division, Ghana Health Service. Okay, so we'd like to ask you, that you are the Director of Research Division of Ghana Health Services. So from the Research Division perspective, what is the important thing that to have policy informing research project? How to make linkage between the national program and research. And what is your experience? You are working in the research center in the intervention site during the project. So I'd like to know your experience and your lesson learned.
So I thank you once more for the opportunity. And as you said, we're to speak on the roles of the research centers in strengthening health systems in Ghana. And we're using the case of Ghana Embrace Implementation Research. My name is Oduro, as has been said already. I'm currently the Director of Research and Development. During the project, I was the Director of Navrongo Health Research Center, one of the implementing sites. But just a bit about the health systems in Ghana. The health sector in Ghana, as you know, is under the Ministry of Health. And Ghana Health Service is the main implementing agency of the service. Within the Ghana Health Service, service delivery is organized mainly on 3 levels. We have the national, regional, and then we have the districts, under which are the sub-districts, with the chiefs that was mentioned earlier on. But health systems research is also an integral part of the health service delivery in Ghana. Health system research has been in part of Ghana health systems for many years now. It's often undertaken by the government institutions, by the health research division and the universities, and also sometimes by the private sector actors and the non-governmental institutions. I'm trying to, so the health, a bit also about the health research division, which Dr. Evelyn Ansah, Professor Evelyn Ansah, who just presented, was the Deputy Director of Research at the time of the embrace. In the Ghana Health Service, health systems research is basically undertaken by the Research and Development Division in collaboration with the various actors within the regions and the divisions. The mandate of the division is really to strengthen, harmonize, coordinate, and support research for policy development and program implementation. I think we need to be clear about this because this is very important with respect to the embrace. Why embrace chose to collaborate the research division, and we did all the work plus other actors in order to ensure that the research was a bit strengthened and it was well harmonized and coordinated. And then we could support embrace so that whatever came out of embrace could be part of policy, which is what we are realizing today. But among the resources of the research division are basically 3 health research centers, which are strategically located in the northern, middle, and the coastal zones. Professor Ansah showed it. You know, within the health research system, we have 3 centers which are strategically located across the country, which enable us to implement research. There are also research units within the regions that work with us to ensure that when research is being undertaken, it's properly integrated and properly done. So I'm just showing you a map of the 3 centers, as you can see them. The one on top is the Navrongo, which is located which was one of the sites of the embrace, located in the savannah part of Ghana. The middle, the Kintampo, which is located in the middle zone, and then the Dodowa, which is in the southern zone. It's our intention to establish additional centers to cover some other areas, particularly the forest zone. These centers are centers of excellence. They support and undertake research activity to address national and global health issues. And like I said, there are also research officers which are stationed within our 16 regions that also support health research, and they all played part in the embrace implementation research. This arrangement, I must say, ensure that health systems research are smoothly conducted in the service, because this structure has purposefully been done to ensure that whatever research that is done can easily move into policy. Because if the research is not properly situated within the service, then there's a tendency that you have your findings and sometimes it becomes more difficult for it to be properly integrated or become policy, and it has its own challenges and problems. But more to the embrace, I would say that as a Director of Research and Development, which replaced my former board, Dr. Hodgson, who was then the director, and as part of the Navrongo, as Director of Navrongo Research Center, we were involved in all aspects of the project, as been done by Professor Evelyn and the earlier speakers. We were involved in the formative research to be able to confirm the existence of the problem we did a baseline survey to gather data that will enable us to properly evaluate the EMBRACE study. We were involved in monitoring the intervention was done by the health systems itself, and we also involved in the evaluation. We took part in the data analysis and report writing and dissemination, including scientific publication. So basically, we're involved in various aspects of the EMBRACE implementation research as part of our mandate of the strengthening and ensuring that research is properly done and properly integrated into the research setting. I'll be finishing soon, but before I move on, there are things that we need to take note, particularly respect to the EMBRACE, as was presented by the immediate past speaker. You see that one of the things that we asked our roles in ensuring that this thing was properly done. You see, we were part of the governance of the project. Many times, for EMBRACE was properly structured because there was, like I said, advisory committee, governance, with respect to governance and policy issues. And then the research division was involved with the governance, we served with it, and we're part in the policy direction. We were also involved in the steering committee, which looked at the scientific bits of the project. And you can see we made our technical input in the design of policy relevant research implementation. It's not every research that can go into policy if it's not policy relevant. So from the start, we're part of the team. We ensured that they adapted the research proposals into a local context in Ghana. We supported the EMBRACE to our colleagues to obtain ethical approval. And we undertook community engagement in the 3 centers that the centers were involved. The research division with 3 centers were involved in engaging the community, engaging the facilities, engaging all the relevant stakeholders within there to ensure that the project was successful. We are part of training the enumerators and assurance of data quality. As part of our work, it's our duty to ensure that whatever data is collected is of high standards, such that it could actually be written out after the project was done. We're involved in monitoring and evaluation of the project, data management, analysis, and report writing. EMBRACE has made a lot of publications in scientific journals, done a lot of dissemination as has been presented by the previous speakers. And each one of these were part of it. So kudos to the EMBRACE team and kudos to the JICA for funding this very all-important project. But last but not the least, I would like to end my presentation with 4 or 5 key recommendations, maybe just for the future of those who want to work, is that the implementation research must be a GS priority and is in line with the health research agenda. Because many times, many other partners who do research who may not be the priority of Ghana Health Service and which are not in line with the national health agenda. When it happens like that, then it is difficult, even though the research can be done, but it's difficult for it to become a priority. As was shown earlier on, you could see that EMBRACE was a national priority because the COC, the continuum of care, there were serious gaps, particularly in the 48 hours, as was re-emphasized by Professor Evelyn. And that means that the nation, it was a priority, and it was proven by data and by all evidence that that was a priority. There was the completion of a continuum of care was quite limited in several settings. And therefore, the intention of JICA to undertake EMBRACE was a welcome news to the GHS and the nation, and to all of us as researchers saw the need to do that. And we also realized one of the recommendations that the research should have a clear policy influence objectives and provide institutional support to enable the roadmap of implementation. I think JICA did not only conducted the research, but JICA had a vision to ensure that this EMBRACE would have institutional, they will provide the necessary institutional support to enable it to become a roadmap, to enable the roadmap of its implementation. So after the study, there were a lot of other series of activities that JICA supported to ensure that the findings became part of policy in the GS, to the extent of helping even to print the maternal health books and all these other things. So this is also very important for future people who may want to undertake research, particularly in Ghana, to ensure that you don't only have to come and do the study, but you should have a clear policy influencing objective, and you should provide institutional support after the study to ensure that the findings are fully integrated into the service and becomes a policy. It must be collaborative. For EMBRACE, the study was a bit collaborative and used the existing health structure. I'm saying the existing health research structure because they work with us as partners. We all agreed what exactly we wanted to do. We all made an input. We serve in various levels of the governance and the scientific team implementation and evaluation. That means that we're very collaborative. But there are many times that you do studies, people come, they want to do studies. Sometimes it's not collaborative, because if you take your own line and you do your own study, sometimes it becomes more difficult. Not that your findings may not be good, but people may not necessarily appreciative of it. And like last but not least, that we must employ strategies that facilitate collaboration and communication, stakeholders, including policymakers and researchers. Like Professor Ansah said, all the policymakers, researchers, and all matter, family health division, all those who matter at the time were all involved. So all these were strategies that ensured that there was collaboration and there was communication between all the stakeholders, ensuring that whatever we were doing were relevant and were appreciated by all. But the last but not the least point I want to state is that we must always understand that for research, there may be different interests and motivation of the different actors. And that at any point in that, we must take that in collaboration, into consideration. And I think for Embrace Research, this was properly done. And I think this Embrace is a showcase. It's a very showcase of a good collaborative research using the existing system, both at the Ghana Health Service and from the university. And I know my boss will be speaking after me, but I want to say that for the division, we are grateful to having Embrace and having JICA, and JICA Ghana in particular, to have worked with us to ensure that at any point in time, you can showcase Embrace Implementation Ghana as a very collaborative study that came from base. That we can present today. Thank you for that opportunity to speak on our role in the Embrace Implementation Research in Ghana. Thank you.
Thank you very much, Dr. Oduro. You kindly elaborated the function of research division and research centers in Ghana Health Services, and how you how the research division made a research structure for collaborative research. And you also pointed out the importance of implementation research in Ghana Health Services. This Embrace project was a combined project of intervention evaluation and implementation evaluation, and it was a very important point of this research. Thank you very much. And next, the last commentator, I'd like to invite Dr. Patrick. Dr. Patrick Kuma-Aboagye, Director General, Ghana Health Service. He is a policy making side of Ghana Health Services, and he is also observing national program and overseeing all the Ghana Health Services. And so I'd like to ask Dr. Patrick to share your observation of Ghana of Embrace project and how it was implemented and how it was meaningful for Ghana Health Services. Dr. Patrick, could you turn on?
Thank you very much.
Thank you. Yes.
And good afternoon. I've been listening in on the other presentation, and it's quite interesting that while this study was going on, I was the then Director for Family Health, eagerly waiting for the results for policy decision. Yeah, so the Embrace study. Yeah. So I'll be talking about the implementation benefits, but I think I will not dwell so much because I believe that the other speakers have spoken a lot about it and how the research, Embrace implementation research supported Ghana to promote the COC in Ghana. And then what were some of the success factors that led to its implementation? It provided us with a very comprehensive documentation of each episode of pregnancy, that is in the continuum from childbirth, growth, development, up to 5 years of age. It also gave us some educational messages on MCH, nutrition, child growth, developmental milestones, and more within the study. And then they also helped us providing health systems and ready-to-use data for planning, implementation, and quality improvement programs. And finally, it was also creating an enabling environment for vital national statistics for information on newborns for inclusion in the population and the demographics programs of the national development. And this was so because a lot of the work, this was a follow-up to what we did as far as all the findings from the Embrace study. And as I was saying before, currently the record book is helping us link children to the national database, and we are currently linking the record book to the Ghana card, which is the Ghana unique identifier. We also found out from the research that it helped us, as was said by other presenters, it moved us from the research base straight into policy because we found that it gave us all the information for capacity building for health workers to explain to mothers and encourage them to seek COC because the research gave us some of the nuances and some of the challenges. It helped us use a home-based record card, which was developed from the Embrace study as part of the documents for the maternal and child records so that we are able to motivate mothers and families to continue care. It also created an enabling environment because of the policy decisions and all the findings that we found that allowed us to not only engage with our clients and the service provider, but also the local government, etc. We're all part of them in the sector that it was done. And based on this research finding, Ghana decided to make the COC part of the client-centered approach. And that was what led to the development of this very popular maternal and child health records book for which we are still using. So like Dr. Oduro said, it helped us, it was very collaborative and also helped us to quickly move from research to policy. There were a few success factors that I think we must highlight. Dr. Oduro and others may have talked about it. This initiative, there was a strong initiative in policy implementation for relevant research because there was the base and there was also collaborative. So we knew that we needed this information to address a challenge that we had as a country. And then Ghana Health Service hold the Ghana MCH conference seminar to share research findings and service providers and the large, including the Embrace implementation also shared. And so we also, the research gave us the impetus to really let people identify the challenges you have and what the Embrace findings will change the landscape of maternal and child health in the country. And of course, the research findings also gave a very strategic information on for policymakers to take this decision. And I'm happy that after the introduction of the record book, I'm also here at the position to ensure that it's implemented to the fullest. And I know that the Ghana government will continue to prevent all these policy relevant implementation research to strengthen the health system. And this creates a very good impetus for evidence that this is important. And looking at the success of their use of the record book, it helps us to know that the research has been very, very useful. We are hoping that to provide quality services and improving the health and well-being of women, children, and the entire population. And once again, just like others, we want to thank JICA for not only doing the research, but also doing the follow-up to ensure that the findings are moved from findings into policy and into implementation to the benefit of all Ghanaians. Thank you very much.
Thank you very much, Dr. Patrick, for elaborating your experience and very important points. After this, we'd like to have some discussion among the panelists. The panelists, could you show up? Could you turn on your video? Dr. Oduro, Dr. Evelyn, Dr. Patrick, and Dr. Shibanuma. Thank you, thank you. We have received a few questions. I'd like to ask the panelists maybe two questions. First, we talked about the collaboration of research and the national program and government towards very feasible and sustainable effective interventions for maternal child health COC. And the first question is, what is the recommendation for other countries to promote such an activity, such a partnership? That is our first question. And the next question is the research. We very often observe that research is not very effectively result in the policy making. Sometimes research is for research, but it is not our objective. So what is your understanding? What is your perception about research? Research is for whom? Research for what? Maybe we are already sharing maybe similar idea, but I would like to know your work. So first questions, based on your experience of Embrace in Ghana, what is your recommendation for other countries? Can I?
All right.
Yeah, start, yes, from Dr. Shibanuma.
All right, thank you very much, Makimoto-san, for the questions. Yes, we are really lucky and delighted to work with the government of Ghana and researchers or practitioners because of the very high level of commitment. So from both the administrators and researchers, as Dr. Evelyn mentioned in the presentation, the very high level government officials from the Ghana Health Service who understand and implement both research and the practitioners. So actively, so this is important, actively participated in the research. And we see a lot of excitement from the field level researchers and practitioners. So when we discussed the importance of this intervention and COC, so Ghanaian side actually had a very strong momentum in implementation of the research. So from the all levels, so practitioners, researchers, top level and field level, that was the really important. So lesson learned and the key to the success. Thank you very much.
Thank you very much. Yeah, I understand the policymakers and the practitioners and researchers, they have different experience, different skills, and different mandates. So it is not very easy to collaborate and work together. But in this project, it could happen. And the active engagement was the successful factors. So I'd like to know the others' opinion about why we could do it, and what is a recommendation for other countries to promote such a collaboration. If Dr. Patrick or Dr. Evelyn, Dr. Oduro, how about Ghana?
Okay, so if I can just make a quick comment. A very important question. I think it is important for such a thing that you seek for local information before you move into policy. Maternal and child health is something that is very linked to the culture of the people and their practices. And so such research is very important, that you do that so that you can change or develop a system that suits the people, because the card is really not for the health sector. It is actually for the mother and the child. Ghana had this unique advantage in the fact that the health research is part of the service. And so it's an integral part of the service. And so there's always an opportunity for us to interact across research, etc. When we have an issue, we push it to them and also share policy briefs with us. So I think that would be a good way that allowed us to be able to have such collaboration. And at the time that was being done, one of the researchers was even the Deputy Director General, who was also a policymaker, awaiting the results so that we can address a very felt need that the nation had actually identified in an earlier study from Maternal mortality survey, when we realized that very few mothers were going from pregnancy all the way to postnatal, and not to talk about the child welfare. So it was a felt need that we needed to really address. And so that's two combination of having research as integral part of the service and the fact that we needed to do important research to be able to unearth how people feel and link it to the culture to address, come up with such a good document. Over.
Thank you very much. The very important point you could point it out. How about
just add to it.
Evelyn? Yes, please go ahead.
Add to it. I think what Dr. Kuma-Aboagye has said is a very important point, involving all the relevant stakeholders and making sure that the local context and the local flavor is looked at and considered. But I think another thing I will add is involving everybody from the beginning which involves the planning and everything, and not when the research is finished and then people are presented with findings and saying the policymakers, can you put this into policy? That is a problem that will not make these things successful. So involving everybody, the health providers were involved from the beginning, researchers were involved from the beginning, policymakers were involved from the beginning, everybody was involved from the beginning. And so we all traveled together. And so when the baby was born, we were all ready to welcome.
Thank you very much, Professor Evelyn. Dr. Patrick and Professor Evelyn's point were really important.
But if the baby is born else, welcome that baby. We may not be as interested in the process. So that's what I will add.
Thank you very much. Thank you very much. I'm sorry that I I stepped in during your speech. The local context understanding and involvement of different stakeholders from very early stage. Those are very important, and that will make a very strong partnership and engagement among an active participation of stakeholders. Thank you very much. Hagiwara-san, do you have anything to add?
Yes, Makimoto-san, thank you very much. As Dr. Patrick Kuma-Aboagye, the DG, mentioned that the local context is so important. And I don't forget that always Dr. Aboagye saying to me that we must involve the practicing midwives and the health workers at the community for the planning. So even for the development of the COC cards or the development of the MCH record book and health messages and health strategies or implementation plan, intervention plan, he said, Akiko, don't forget, invite the practitioners and the target mothers also, that you must listen to the mother's opinion. So it's important to involve the top policy makers from the beginning and also international partners like UN organizations, UNICEF, WHO, and to follow their strategies. But at the same time, he said that we must go to the fields and listen to our target population, which are the community health workers and the mothers and family members. So we must listen to those end users, frontline health workers' opinions for the research and also for the policy making and for the development of the tools like COC cards and MCH record book. So that's what I really learned from the Dr. Aboagye, working in Ghana for last 10 years. The structure of the advisory board and the researchers' meetings, those regular communication structure is another tool to promote the good collaboration. So the UNICEF, WHO, the UNFPA, those are involved from the beginning because we had the advisory board and we had the regular communication with them, which were very good tool for us to collaborate and work together. So that, as Dr. Evelyn says, the involvement of all the stakeholders from the very early stage was very successfully done in Ghana. And it was one of the successful the factors for the success. So that's my comment. Thank you.
Thank you, Akiko-san. That to sustain, to promote the active engagement, the structure is important, and strong leadership, like Dr. Patrick, is quite important. Thank you very much. Our last commentator, Dr. Oduro, are you still there?
I'm there.
Yes. If you have any comments.
Oh, I'm okay. I guess the director of Ghana Service has spoken. He's spoken the views of Ghana, and that's why Evelyn too has spoken. He's now in the academic and he's also spoken. So I guess it's okay. We have enough on what the way forward. So I will take it like that. Thank you.
Thank you very much. From all the presenters, speakers' word, we learned very important key issues to promote the very practical research and successful research for the policy informing. Before, I think the time is already close to close, so I'd like to wrap up the discussion. But if you have anything to add, is there anybody who would like to say something more? If not, yes, Professor Evelyn.
Let me just show you. No, I can't share my screen. I just wanted to show 3 pictures to you, but if it says yes, I cannot share, So let me just share with you. This shows what we've been talking about. And I just wanted to show you these pictures. These are mothers. This is a picture of a mother who is talking about the COC card. This is health workers who are saying that now they can spend time on each mother and give them the quality of care they need to give them. These are midwives who are talking about how they've managed to get mothers to stay for postnatal care. This is a mother who is talking about the fact that traditionally they don't go out for 40 days after delivery, and therefore the visit by the health worker to the home is very important. And this is that's postnatal care, discovering problems very early. And finally, the importance of the 24-hour retention by a very experienced midwife. Thank you very much.
Thank you very much for sharing the very good the various mothers and babies story. It is very very informative to the participant to understand what Embrace made in Ghana. Thank you very much. So from this session, we learned that the Embrace made a very client-centered tool and the system for COC completion, and sharing the maybe same vision to achieve COC completion from very early stage was very effective factor, and the involvement of different stakeholders from very early period made implementation also very effective, not only intervention but implementation. And community practitioners' involvement is very important, and leadership of policymakers level is important. And to sustain the long-term period of research, the research structure is imperative, and COC card is a good communication tool for empowering mothers and supporting community health workers. And it is very easy to share the vision of COC completion. The local context sharing, understanding is the most important thing to have good design of the research, and the strategic process of designing, implementation, and dissemination, and scaling up. That's kind of very broad scope is also important thing we learned from today's session. Thank you very much for all the presenters for contributing to this session.